Well, hello everyone, and welcome to this continuous professional development activity entitled Tobacco Use and Poverty in the USAPI, that's the United States Affiliated Pacific Islands. Why do the poor smoke? As many of you know already, my name is Professor Brian Mangum, and I'm a consultant epidemiologist and an assistant professor of epidemiology in the School of Public Health and Primary Care at Fiji National University, and I'm also an assistant professor of epidemiology and public health in the Public Health Training Program at the College of Micronesia, FSM, here at the National Campus in Pohnpei. And as many of you know, I'm being brought to you today by a grant from the University of Arizona and the Pacific Island Health Officers Association as part of an effort to bring continuous professional development activities like this to the public health, the nursing, and the medical workforce across the USAPI. So if you're listening from across the USAPI, welcome, welcome. If you're listening from any other place in the world, you're welcome to join us as well. Okay, so what are we going to talk about today? Well, the primary focus of this lecture, and I'm hoping to keep this one around 20 minutes, is this question of why do the poor smoke? Okay, because we know from really good statistics from around the world that by and large in most countries it's the economically disenfranchised populations who smoke the most and consequently bear the largest burden of morbidity and mortality associated with smoking, such as asthma, COPD, chronic lung disease, as well as lung cancer and ultimately death. Now we know that about 50% of individuals who smoke will ultimately die, and so if the bulk of those individuals come from economically disadvantaged backgrounds, then that's a significant public health issue. And what you're going to see here in a moment is we're going to talk about an overview of the tobacco epidemic in the USAPI, and we'll be talking in particular about some statistics from the Federated States of Micronesia, also from the Republic of Palau, and from the Republic of the Marshall Islands. Now, I was unable to find a whole lot of statistics from Guam and CNMI and American Samoa, and I'm guessing that's probably because those statistics are largely buried within the statistics for the larger United States, given the different political relationships that those jurisdictions have with the United States. But we will go through FSM, RMI, and Palau and look at things like adult smoking rates, child and adolescent smoking rates, rates of smokeless tobacco consumption, and then we'll also talk about deaths from tobacco. So that's the first thing we'll talk about. Then we'll move on and we'll talk about smoking and health inequalities, and that's really going to focus on the topic of the richer you are, all right, the less likely you are to smoke, and that's going to turn into a discussion, our third discussion, of the challenges of being someone who comes from a low socioeconomic status. So in other words, we're going to talk about how exposure to risk, or in other words, exposure to the risk of lung cancer by being exposed to tobacco, either through direct consumption of the tobacco, smokeless tobacco, or living in a home where there is secondary and tertiary exposure to tobacco, how that is actually a product of socioeconomic status. In other words, the lower you are down on the socioeconomic status ladder, the more likely you are to be exposed to tobacco, and consequently the more likely you are to develop one of the chronic lung diseases and ultimately die from that tobacco exposure. So in other words, once again, exposure is going to be a risk, exposure to risk is going to be a byproduct of socioeconomic status, and we'll get into specifically what socioeconomic status is. Then we'll move on to number 4, and we'll talk about the challenges, okay? A little bit more on the challenges of being from a low socioeconomic status background, and we're going to talk about how that directly links into low health literacy levels, okay? So in other words, the less educated you are, the less your general education literacy level is, and consequently the less your health literacy level is, and the more likely you are to engage in inappropriate health behavior simply because you don't know better. And then what we're also going to do is we're going to talk about this concept of immediate gratification. So in other words, if you come from a low socioeconomic background, not only do you have lower health literacy levels, but you may essentially have less to live for in many ways. Okay, and there's some good research that looks at this. In other words, it looks at the fact that the poor look at life a little bit differently than those who come from middle and upper income levels. So in other words, the poor tend to seek immediate gratification. They don't look 5 years down the road and say, well, in 5 years, my bank account's going to have this much money. And in 10 years, my bank account's going to have this much money. And then in 15 years, I'm going to be ready to retire. Or things like in 5 years, my kids are going to be ready for college, so I need to have have X number of dollars set aside so that I can pay their college tuition. They don't necessarily look at life that way. So in other words, they turn to things for immediate gratification in the moment. And one of those forms of immediate gratification in the moment that they can have is the use of tobacco products, because it gives them some type of gratification in terms of the actual nicotine, all right, the nicotine high that comes. And then they also get the immediate gratification of, they generally associate with others who smoke as well. So they get the social gratification of being included in the group with their friends, family members, and so on and so forth, okay? And then that's going to lead us into point number 5. So why do the poor actually smoke? Well, what we're going to see is it's going to be a combination of education, like we talked about, or socioeconomic status, leading into that lower levels of health literacy, okay? And then we're also going to talk about how it can actually be a form of self-medication for the stress that comes from a life of living, wondering where your next meal is going to come from, how are you going to pay your kids' school tuition, you know, and so on and so forth, and things like that. And then also that issue of lifestyle, of being associated with other smokers, and then also the issue of immediate gratification as well. So let's start out talking about the tobacco epidemic across the USAPI, and we'll start out with the Federated States of Micronesia. Now, all of the statistics that I'm going to give today, they come from the Global Tobacco Atlas, and there is actually a reference to that at the back of the slides if you want to go look at those statistics for yourself. And so what you'll see is in the red circle in the center there, there's a 1, and that simply refers to the reference list. So if you look in the reference list under number 1, you'll find the reference for the Tobacco Atlas for the Federated States of Micronesia. It's a wonderful resource, and I encourage you to go look at it. One thing that's included in the Tobacco Atlas that we're not necessarily going to talk about today is there some information about public health and media campaigns and some best practices that are recommended by the World Health Organization. And there's information back there, if you look in the Tobacco Atlas, as to whether or not specific countries are engaging in these best practices. For those of you who are public health planners, this is a great resource to go and see how does your jurisdiction measure up against other areas in the Pacific, and in particular against these WHO standards. And so you can see the shortfalls in your particular jurisdiction, and you can help plan to rectify those shortfalls in the future. So anyway, back on our topic here, talking about the tobacco epidemic in the FSM, every year more than 70 people in the Federated States of Micronesia are actually killed by tobacco-related diseases, okay, while more than 1,800 children and more than 91,000 adults continue to use tobacco each day, okay. Now, comprehensive tobacco control policies, which cover all forms of tobacco use, would actually reduce the death toll from tobacco in places like the Federated States of Micronesia and Palau and so on and so forth, okay? And if we don't have some type of integrated control programs that come from both a legislative as well as a public health and a health promotion standpoint, as well as the individual work that our providers can do in working with individual patients, such as our nurses and our physicians, then what we're going to see is that every year the tobacco problem across all of the USAPI is going to continue to grow and grow and grow. And the other thing that you would see through the development of these tobacco control programs is that essentially what they would do is they would stop the tobacco industry from running roughshod over the lives of the people of the Federated States of Micronesia, okay? And so what we really encourage from a public health standpoint is we encourage tobacco control advocates to reach out to both government agencies as well as to development organizations across the USAPI to help formulate tobacco control programs, okay? Now, there's some wonderful videos on the internet you can go look at, and you can look at how companies like British American Tobacco and Philip Morris and so on and so forth, how they maintain essentially what is a stranglehold over developing countries like the Federated States of Micronesia and Palau, and even places like the Solomon Islands, where when these countries attempt to implement comprehensive tobacco control policies, essentially what companies like Philip Morris and British American Tobacco do is they come in and they threaten to sue. They threaten to sue for trademark infringement and patent infringement and things like that. And they threaten with such huge lawsuits, oftentimes lawsuits that are more than 100% larger than the gross domestic product of the country. And so a lot of times these countries like the Solomon Islands and a lot of countries in Africa like Cameroon that have very small, have very small amounts of resources. Essentially what they do is they back down out of fear from the tobacco companies, and they don't put tobacco policies in place because of that fear. Okay, so let's look at some of the statistics. Let's start out by talking about adult smoking rates. Okay, and what you can see is that we have a large number of both a particular number of males that smoke, and in fact more men on average smoke in the Federated States of Micronesia compared with other middle income countries. And even though only 11.5% of women are actually smoking in the Federated States of Micronesia, this is still more women on average than we would see in other low to middle income similar nations. Okay. We also see that we have a significant problem with children and adolescents using tobacco. In fact, what do you see? You see 36.9% of boys and 19.8% of girls are actually smoking tobacco. So if you compare those numbers against the adult smoking rates, what we can anticipate is that the rates of smoking are actually going to go up in the adult population as we see these boys and girls reach adulthood. Now, obviously, there's a significant problem with smokeless tobacco as well, so that would be like chew, okay? And we see that 11.4% of adults are actually using smokeless tobacco, which once again is more people on average in the Federated States of Micronesia than we would find in similar settings. Now, there's also the issue, and I don't have any statistics on it, this issue of the e-cigarettes, the electronic cigarettes, that are becoming a problem. And in terms of innovative and cutting-edge approaches to deal with e-cigarettes, I would like to single out Kosher as one of the states of the Federated States of Micronesia, which has actually outlawed the importation of electronic cigarettes. So in many ways, Kosher is cutting edge. So way to go, Kosher. Here we are out here in the Pacific, and you're doing things that not even places like Canada and the United States are doing. Okay. So what does this do? This brings us around to the upper left-hand corner. What do we have in terms of tobacco deaths? Well, 5.6% of all deaths, and this is a data from 2010, which is some of the more recent data. So 5.6% of deaths among females are from tobacco. So what that means is we have one tobacco death every other week. Okay, and if you look at males, we get 13% of all deaths are related to tobacco among males. And so what this means is what? It means that that's one tobacco death every week, okay, in the Federated States of Micronesia. And as you know full well, when we lose an adult member of the household, okay, that puts a significant stress on the household. Maybe that's the primary breadwinner for the household who's died, okay? And that in turn places a greater strain on the family and on the community and indeed on the entire Federated States of Micronesia, because that's an individual that was a productive member of society and has now been removed from that productive role. Now, of course, much of what I had said about the Federated States of Micronesia in terms of the need for consolidated and legislative control of tobacco is also going to apply to the Republic of Palau as well as to the Republic of the Marshall Islands as well. So I'm not necessarily going to mention that. The one thing I will mention is the world's 6 largest tobacco companies in 2013, they had a combined profit of, get this, $342 million US, okay? That is many, many, many times larger than the gross domestic product of the Republic of the Marshall Islands, the Republic of Palau, and even the Federated States of Micronesia put together. And with profits like that, it's not surprising that they have the resources to come to places like Southeast Asia, the Pacific, and Sub-Saharan Africa, and they have the ability to make the threats of the lawsuit. They have the ability to come in and fight our efforts at legislative control, okay? Which is why it's more important than ever that we be able to implement specific legal remedies to the problem of tobacco use before the tobacco companies are aware of what's happening in these areas, okay? So if you look at adult smoking rates, what do we see? Okay, we see 37.2% of adult males and 27% of adult females, which once again is significantly higher than we would see in other low-income countries. So it's a big problem here, okay? Now the particularly stunning statistics that we have here is if you look at children and adolescent tobacco use, more than half of all adolescent boys are currently using tobacco in the Republic of Palau. That is a huge balloon of smokers that as they enter adulthood and as they enter into middle age, these kids are going to, well, they'll be adults by then, these individuals are going to do what? They're going to place a tremendous strain on the medical resources of the Republic of Palau to treat chronic obstructive pulmonary disease, to treat asthma in the home of the children of these individuals, and also to treat lung cancer with off-island referrals, okay? And in fact, we have some really good statistics that show actually the lung cancer death rates or the survival rates from lung cancer actually haven't improved much since the 1950s. There still isn't a whole lot that we can do. So if we take this huge population of individuals that are at greater risk, okay, of having lung cancer, and remember 50% of all those individuals who smoke will actually die from smoking, and the number one cause of death is going to be lung cancer, all right? And we thrust these individuals into the medical system in the next 40 to 50 years, okay? And we have very low survival rates. So in other words, we're going to be throwing money away at that point, okay? Money that could be better spent on what? Could be better spent on prevention and could be better spent on educating our children, building roads, infrastructure, and so on and so forth. So particularly for the Republic of Palau, they have a significant problem in terms of health services provision coming down the road in the next 40 or so years. And that's something that if you're in the Republic of Palau, you need to be planning for, okay? Now, unfortunately, if you look at the rates of smokeless tobacco and the tobacco deaths, the Global Tobacco Atlas doesn't have that information as of this time. Now, I'm not saying that information isn't available. I'm sure it's being collected by the Republic of Palau, but this is one of the problems that we see in terms of data collection across the Pacific. Data may be collected, but if it isn't necessarily reported up the chain to places like CDC, WHO, and so on and so forth, then it's not necessarily available to researchers and policymakers, okay? Okay, finally, let's talk about the tobacco epidemic in the Republic of the Marshall Islands. All right, now if you look here, what you see is RMI actually has lower rates than some of the other jurisdictions across the USAPI. And so even though we see fewer males and fewer females that are actually smoking in RMI than in Palau and FSM, these are still rates that would be higher than what we would see in other low-income countries. So in other words, even though the rates are low, RMI still has higher rates than other developing countries. Consequently, they'll have higher expenditures, higher numbers of patients, higher demand upon the medical and the public health system, okay? Same thing with children and adolescent tobacco use, 17% of boys, 10.6% of girls, so significantly lower than we saw in the Republic of Palau, but still a concern, okay? But if you compare this against adult smoking rates, it might actually indicate, and I say might, okay, I'm making a supposition here, a hypothesis, it might actually indicate that in the coming decades we'll see that the rates of adult smoking will actually go down in the Republic of the Marshall Islands, okay? We do see a problem with the use of smokeless tobacco, with 13.5% of adults using smokeless tobacco, which is higher than other countries. And even though we do see lower rates than other low-income countries for female deaths and for male deaths, we are still seeing approximately one male death every week, and that's a preventable death, okay, in terms of tobacco use. So let's really quick talk about smoking and health inequalities as one of the challenges of low socioeconomic status, okay? And in just a minute, I'm going to define low socioeconomic status just so you know what I'm talking about. Now, socioeconomic status, or abbreviated SES, is not just how much money you make, okay? That's a common misconception. Really what it is, it's a combination of your education, your employment, and your family's economic background, okay? And what we're going to see in the next slide is that oftentimes more than how much you make, the important factor is going to be your level of education, Okay, because what you're going to see is that the level of education is going to play a role in general literacy, and it's going to play a role in your level of health literacy. Okay, so in other words, do people understand the risks of tobacco use? Do they understand the actions they need to take to quit smoking or not to start smoking? Okay, and so that's going to play a huge role. Okay, all right, now the poorer populations that we have out there across the USAPI are more likely to smoke. Okay, and we've already mentioned that smoking is going to account for 50% of the difference between the rich and the poor life expectancy. So in other words, poor people don't live as long. Okay, poor people do not have as high a level of education. So does poverty itself directly cause smoking? No, poverty itself does not directly cause smoking, but poverty is going to be a determinant of smoking. In other words, it's going to be one of the underlying factors that causes an individual to be more susceptible to take up cigarette smoking. Okay, we also know that children from poor homes with smokers are themselves more likely to smoke. Okay, because they see it as a role model, and that's also going to be a problem in terms of our ability to get children to not start smoking, but also going to be a problem in terms of getting adults who are smokers to quit smoking. Because why? They hang around in a social group that tends to include other smokers. So one of the things that we do when we have individuals go through tobacco cessation programs is we have what we call the rule of no thumb. So if you hold up your hand right now and you put your thumb down, what do you see? You got 4 fingers that are sitting up. Now the rule of no thumb simply says that an individual will probably have to go through tobacco cessation 4 times before they actually become fully abstinent from the tobacco. And it's actually a similar thing with alcohol and other drugs as well. So in other words, one of the problems is if you've got an individual going through the tobacco cessation process and they still hang around with smokers, they get all these wonderful psychological cues that they too should be smoking. They smell the cigarettes, they're around their friends are smoking, their friends are drinking alcohol. Maybe they're hanging out with their friends on a Friday night in the bar. Maybe they're just sitting around drinking cacao or kava and their friends happen to be smoking. So you get that social reinforcement that is so hard for these individuals to break away from. And because they also happen to be from a lower socioeconomic level, or they happen to be more likely to live in poverty, it's more likely that they also are going to be smoking. Okay, so all of these factors work together to predispose the poorer members of the USAPI to smoke. Okay. Now, what about smoking and women as well as pregnancy? Now, we know that low-income women are 3 times more likely to smoke while pregnant than women that come from middle and upper income brackets. Why is that? Well, there's a couple of different theories that could explain that. The most likely is simply they don't have the higher level of health literacy that we keep talking about to understand that smoking is very bad during pregnancy, associated with low birth weight infants and so on and so forth. Okay. We also know that women who engage in manual jobs or blue-collar jobs, okay, because they have lower levels of socioeconomic achievement, they have lower levels of education, they're more likely to smoke than women that work in professional or managerial level jobs as well. So once again, it isn't necessarily that poverty itself is directly linked to smoking, okay, or a direct cause of smoking. It's this association of the lifestyle of the poor individuals, okay, of their lower socioeconomic status, the people they hang around with, the jobs that they work in, that are going to in turn cause them to be more likely to take up smoking cigarettes, okay. And that's all can be associated with income as well. So you see the balloon there about smoking and income, and we know that 50% of smokers do what? They work in manual labor occupations, and we tend to find that individuals that work in manual labor occupations hang around with other manual laborers, and if there's smoking involved, we once again get that social and that psychological reinforcement. Okay. We also know that quitting smoking is significantly more difficult for people who come from lower socioeconomic status bands, okay? They do tend to find it more difficult to quit, and we've talked about some of the psychological reasons for that. The people they hang around with tend to not support efforts to quit, okay? It may be that the family also includes, maybe there are other people in the household that smoke, and so not only is there that constant social reinforcement of being around the smokers and the psychological cues of smelling the smoke, wanting the cigarette in the morning when they smell the coffee or when they see the men sitting around drinking the kava or something like that, but there's also going to be this idea that they smoke more cigarettes and consequently consequently they tend to be more addicted, and that once again makes it considerably more difficult to quit. And then the other problem that we're going to see with these populations is, once again, there's that low health literacy level, and they don't necessarily know what resources are out there for them to quit smoking. Okay, so they are less likely to see a physician on a regular basis, and when they do see the physician is actually less likely to ask individuals from low income settings whether or not they smoke. Okay, so for those of you who are my providers out there, my physicians, my nurses, my nurse practitioners, my PAs, if they happen to be out there, and I know this is something that we actually discussed about at the Pacific Basin Medical Association late last year, is one of the best things you can do for your patients, regardless of whether or not they're rich, they're poor, they're middle income, is you can ask them, do you smoke? And then you can say, why do you smoke? And then you can use the important phrase, the best thing you can do for your health is you can stop smoking. And bug them, remind them of that at every appointment that they come to. And then go beyond that. Know what the resources are in the community. Tie yourself in with the public health agencies in terms of understanding, are there smoking cessation clinics available? Are there programs available in the community that individuals can take advantage of? Okay? And for my public health planners, are there programs available in your community? Could they be strengthened? And how do you go about strengthening those programs and making sure that the poor have access to them? Now, we've talked about this already. We've talked about the fact that there are many factors that contribute towards predicted tobacco use, okay? But really, socioeconomic status is going to be the single greatest predictor. So in other words, the lower your income, the more likely you are to be a tobacco user, okay? So I already talked briefly about what SES is. Remember, it's a combination of your education, your employment, and your family's economic background. So why is family economic background important? Well, you've heard of the poverty cycle, where we get generations of individuals living in poverty because they lack the resources to attend college and get a higher level of education and to break out of that poverty cycle. Okay, so family economic background is actually directly associated with academic achievement, and as you know, academic achievement is directly associated with stable and profitable employment. So in other words, socioeconomic status plays an enormous role in determining whether or not individuals have higher levels of health literacy, and it's also going to determine the types of health behaviors that they engage in. So in other words, the higher your socioeconomic status, the more likely you are to understand the risks of tobacco use and consequently not begin using tobacco, or the more likely you are to take advantage of tobacco cessation programs, okay? And like I said, tobacco and poverty really does create a vicious cycle, because we know that low-income people smoke more, they suffer more, they spend more, and they tend to die more from tobacco use. So who would we lump into low socioeconomic status populations? Well, this includes low-income individuals, individuals that tend to have less than 12 years of educational attainment. Okay, this would also be the medically underserved populations that we have across the USAPI, individuals who are unemployed, individuals who are mentally ill, all right, tend to consume a disproportionately large percentage of the tobacco and alcohol products worldwide. Okay, and just as a quick aside, if you go to my YouTube site, there's actually a YouTube lecture entitled No Public Health Without Mental Health, and it actually talks about how do we integrate mental health services into the public health system, and it puts a huge focus on the reason for doing that is that those who are mentally ill tend to have worse health and tend to be more representative of the burden of non-communicable diseases worldwide, as well as here in the USAPI. So if you go out and watch that, I'm happy to provide you a certificate of professional development activity for that lecture as well. Okay. Other individuals who tend to be of low socioeconomic status and tend to have higher rates of tobacco consumption would also be individuals who are incarcerated, so prisoners, blue-collar workers, and like I mentioned, the mentally ill already. And also we know that gay and lesbian populations also tend to be more likely to be of low socioeconomic status and also actually have higher rates of tobacco consumption as well. All right, so what are some of the specific challenges of having a population of low socioeconomic status and that being the single greatest predictor of tobacco use? There was actually a study conducted by the National Network of Smoking Prevention and Poverty, and this was in the United States, and they found that cigarettes served as a tool for those of low socioeconomic status to cope with things like boredom, all right, to relieve stress, and also to serve as a companion to alcohol as well as caffeine. And then we talked briefly, remember, about that social connection. If you hang around with smokers, you drink your Sakau with smokers, you drink your kava with smokers, and you spend Friday night hanging around with your friends and they're smokers, that all reinforces the use of the tobacco and makes it doubly difficult from a psychological standpoint for these individuals to quit. Now, what else do we know from other studies that have been conducted in similar settings to the USAPI, so places like Sri Lanka and the Caribbean, which is where I call my previous home before the Pacific? What have they showed? Well, they've showed that store promotions served as major incentives to get tobacco, to get the poor to begin to smoke tobacco, and in particular to get teenagers and young adults to begin smoking. Okay, and one of the things that we see from that is that there tends to be high brand loyalty among tobacco users based upon the promotion of tobacco in stores. And so a lot of times what you have is you have these tobacco users, and they see their cigarettes, and in particular they see their brand, their Marlboros, their Camels, maybe one of the Chinese cigarettes that are now being imported into the USAPI. They actually see it as a loyal friend during times of stress. All right, and they also see it as a loyal friend during times of joy in their life as well, when they're hanging around with their friends. Okay, the other thing that we see, and in particular in the Pacific, is we are a lovely people. We like to share with each other. So if we have food, what do? We say, time to eat, and we invite our friends over and we share our food, all right? We tend to be a very giving people, and one of the studies that I looked at shows that we also tend to be very giving with our tobacco, okay? So maybe we can't afford lunch, but maybe we can afford 2 cigarettes from the tobacco cart, and so we get 2 cigarettes and we share one with our friend. Okay, so that's a significant cultural barrier that we need to overcome as well. I know that, and I don't have the exact reference, but there was a presentation at the Pacific Basin Medical Association in 2015 in Palau, and there was a group of researchers that actually came from the University of Guam, and what they showed was that tobacco advertising in Guam, in terms of the convenience stores and even the grocery stores, was very targeted towards children. So in other words, sometimes you found the tobacco products being advertised alongside diapers, all right? Well, that would be more for the mothers, and formula and things like that, but you also found them at a lower level. So you found them down at the eye level of children, all right? And so obviously the tobacco advertisers are attempting to target younger and younger smokers so that they can have that future audience captive, okay? Now, the other thing we know is that individuals tend to not relate smoking directly to deadly illnesses such as lung cancer, okay, and they tend not to connect smoking directly to health risks, okay. And in fact, in some studies where they talked to people of poor socioeconomic status, they found that these people perceived secondhand smoke as being more harmful than directly smoking themselves. So there is that lack of health literacy as well. Now, I do want to mention that sometimes we look at legislative solutions. So in other words, we look at things like raising the tax on tobacco, okay? Now, there is some literature, okay, that would suggest that that is an effective method, but only to a certain level. Okay, so in other words, we can raise the tax on tobaccos, and that does have a public health impact in terms of getting some people to quit and other people not to quit, but it's a finite line. So in other words, we raise the cigarette tax too high, and instead of forcing individuals in this segment to nearly to stop smoking or to not smoke, what they do is they buy down. In other words, they start buying generic brands, okay? Or some individuals actually may start buying tobacco itself and rolling their own cigarettes when we reach that critical mass of the tobacco tax there. Now, I'm not saying we shouldn't tax tobacco and alcohol products and other sin products like that, that is actually a perfectly good legislative solution. I'm just saying there comes a point where raising the tobacco tax any higher doesn't necessarily price individuals out of using cigarettes if there are generic cigarettes available. And I know that that's a problem that we have here in the USAPI with the importation of tobacco products from China. So in other words, we need to make sure that the tobacco products imported from China are equally taxed, okay? And we need to make sure that from a customs and revenue standpoint, that they are priced at a level that doesn't make them a cheap alternative, all right, to American brands or British brands of cigarettes. And then the other thing that we need to do in terms of an enforcement function of public health is we need to make sure that our customs and revenue services are accurately identifying tobacco products that are being brought in international mail by individuals and not companies into our countries, and then being resold in the small food stalls. Okay, 1 cigarette at a time, 2 cigarettes at a time. All right, especially when these are coupled with betel nuts and lime and things like that. And we'll actually do a discussion on betel nuts possibly this month, maybe next month as well. Okay. Now, the other thing that we see with these individuals is we see unsuccessful quitting attempts and relapses, okay? And what are these unsuccessful quitting attempts and relapses caused by? Well, they're caused by the stress of living in a low socioeconomic band, okay? Will I be able to feed my family? Will I be able to keep the power on? Will I be able to afford the kerosene for the stove so I can make the roti and the breadfruit and things along those lines, okay? And then there's also the unsuccessful quitting attempts that are caused by the psychological determinants. So we already discussed, in other words, friends and family that do not support the individual quitting, going into environments such as bars and hanging out with friends where smoking is common and accepted, and all reinforces the need to smoke as part of being part of the crowd there. Okay? And then I've also mentioned this already, there's also this lack of inquiry by providers, so by physicians and nurse practitioners, as well as little advice or support by doctors to help the individuals quit, okay? And then some patients actually admitted that when they, or some patients indicated that when they admitted to their provider that they smoked, they weren't treated with respect. In other words, they were actually scolded and made to feel belittled by their provider about being a smoker. So in other words, the other caveat to the point I made earlier about our providers need to be screening for tobacco use and then providing access to services in the community is you need to do it in a supportive manner. Don't be judgmental, okay? Same thing we would find with an alcoholic or an individual with mental illness, okay? We don't want to be so judgmental that these individuals fail to stay within the health system. In other words, they develop a bad attitude because their doctor had a bad attitude, and they simply say, well, I'll smoke all the cigarettes I want, and not only that, I won't come back to the doctor to get my diabetes medication, or I won't come back to get my hypertensive medication, all right? So we want to provide a supportive medical home in which these individuals can receive the support and the resources that they need in order to quit smoking. And then the last thing that we find in our poor patients who smoke is a lack of self-efficacy, okay? In other words, they don't believe that they can quit, okay? So for those of you in health promotion and in health planning, this is the health belief model. Please go out and review that for those of you who are planning tobacco cessation programs. The health belief model is a psychological model that explains why people won't change their behavior, and then also takes us through a series of steps in understanding why they won't change their behavior and what we can do to help them change their behavior. And the tip top of the health belief model is that a patient achieves self-efficacy. In other words, they believe they can change, and they're willing to take the actions needed to change, and it becomes a sustainable change in their life. Well, if our poor patients don't have a supportive environment, a psychological environment, a medical environment, and access to resources in which they can change, they are not going to believe in themselves, and they're not going to take the necessary steps to stop smoking. And that is a significantly, frequently identified barrier among our low socioeconomic patients, okay? They don't believe that they can quit, okay? So we wrap it all up with this question of, so why do the poor smoke more? Well, much of it we've already talked about. Okay, we've already indicated the reasons that people tend to smoke more. The psychological environment, the stressor, the self-medicating for life stress, being around others who smoke, lack of health literacy, and things along those lines. Okay, well, let's just kind of try to wrap all that into one single slide here. So as we've seen, smoking tends to be more prevalent among the poor than the rich in most settings. Okay, now, like I said, the reasons for this, we're getting some good data, but sometimes the reasons are not particularly concrete, okay? But these are the currently accepted reasons and the currently accepted theories that we have that are supported by the research and the literature that we have out there. So in other words, several hypotheses have been put forward to explain the socioeconomic gradient in smoking, okay? Now, these hypotheses generally relate to developed as well as developing countries. So in other words, they are applicable out here in the USAPI. Okay. Now the first of these is that it's argued that the poor and the less educated are less aware of the health hazards of smoking and thus more likely to adopt the harmful practice. And we've talked about that already. Now second, it's also been argued that smoking may be a form of self-medication to regulate mood, manage stress, and even to cope with the strains of material deprivation. So in other words, not having access to resources. Okay. Now, there's some literature that would indicate that the self-medication hypothesis is not very tenable due to the lack of a sedative or an anxiolytic effect of the nicotine. Okay, but what I would argue is that this form of self-medication, rather than being a pharmaceutical form of self-medication, it's actually a psychological form of self-medication. All right, so in other words, it's psychologically reinforcing to get the immediate gratification of having the cigarette and the release that comes with the nicotine, coupled with the fact that it goes along with socialization with friends and family who also are smokers and who also happen to come from the poor reaches of the socioeconomic ladder. Now, the third one we can talk about is that it's argued that the adoption of smoking may be a replacement reward, okay, as smoking is often described as one of the few things a poor person can do for himself. Okay, can't afford a car, can't afford to go to the movies, okay, and we do have a movie theater here in Pohnpei, and I know there's movies in Guam and also in Saipan. Can't afford that new iPhone, can't afford all the things that you see around you that people are getting. Well, an immediate form of gratification can actually be that cigarette, okay? Now, the fourth one is that economic hypothesis would suggest that given the same perceived benefits from smoking, a person whose income is low would have less to lose from future health problems than a person with higher income. And so in other words, like we mentioned at the beginning of the presentation, sometimes they see themselves as having less to live for. In other words, like I said, they don't see themselves 5 years down the road of having X number of dollars in the bank, being this much further along in school, being this much further along in your career progression, progressing to a managerial position, seeing your children grow up and go to college and be successful. A lot of times the poor simply don't have that in their lives, okay? And so once again, they don't have a bright future to protect with good health, so why not smoke right now? And there is actually really good data that supports that view among the poor. Okay, and then finally, there is some evidence to suggest that the extent of nicotine dependence in poor smokers tends to be greater. Okay, so in other words, they smoke more cigarettes, and consequently, the dependence upon the nicotine, or in other words, the chemical dependence, tends to be greater among the poorer populations as well. Congratulations, you did it. And look, well, I promised you I was going to try to keep this down to about 20 minutes. Looks like we're going to hit about 45 here. So, what do you need to do now? I want to give you a certificate of professional development for this activity. You listened to me for 45 minutes and hopefully you learned something about why the poor smoke more, and I want to give you a little reward. You can see that lovely, suitable for framing, very, very handsome certificate of professional development there. I want to give you one of those, okay? You email me at the address you see there on the screen, brian.mangum@fnu.ac.fj, and I am more than happy to send you that certificate. When you email me, tell me who you are, where you work, what your job title is, and maybe tell me one or two things that you learned from the lecture today, and I'm happy to send you out that certificate of professional development, which will be signed by me. It's endorsed by the Micronesia Area Health Education Center, which comes under the Guam AHEC, okay? And it's good for a variety of different things. For my physicians, you can use it for continuing medical education. For my nurses, CNUs, for anybody who needs to earn a certain number of continuing education credits per year, you can use these professional development activities for those. So send me the email, and I'm thrilled if you'll do that, and I'll send you that certificate. And here we just have the reference list. So you see there were six primary references that we used today. And like I said at the beginning, I encourage you to go out and look at the tobacco atlas yourself. It's full of great information. And once again, thank you for your hard work. Thank you for your dedication. Public health, medicine, nursing, whatever your field is, it would not be the same here in the Pacific without you. So keep up the good work, and thank you.